Good evening, friends. This is Dr. Rajkumar. On behalf of IPS Vadodara and Bombay Psychiatric Society, I welcome you all this evening, The Brain on Wednesdays, to take you more about the topic and to introduce the speaker. I request Rukshada to take over.
Thank you, Dr. Rajkumar. Good evening, everyone. I have the pleasure of being the president of Bombay Psychiatric Society, and also I'm very, very lucky with friends like Malay and Bhaskar and Dr. Rajkumar, who very easily set up these amazing webinars, and which helps us learn and helps BPS further the cause of biological psychiatry as well. So with that, I am going to introduce our young presenter today. She is Dr. Susmita Sarkar. She's done her MD from AIMS, and she binge watches a whole lot of content, just like you and I, apparently. I don't know about others, but I definitely binge. She's currently an SR, so I'm wondering, between binge watching things, really knowing and learning so much about psychiatry and in working as an SR, where does she take that time? So we'll get that kind of information from her later. But I cannot wait to share her presentation today on it's such an important topic, because all of us grapple with this, all of us see that on a daily basis in our clinical practice as well. And that kind of helps either us write our prescriptions or not write our prescriptions. So with this, I'm going to hand it over to Dr. Rajkumar, who may say a few words on the topic, and then hand it over to Susmita.
Thank you, Rukshada. Yes, friends, we have three types of medications on our hands, usually that we use in our day-to-day practice, broadly assigned as antipsychotics, antidepressants, and anti-anxiety medications. A big chunk of it in the antipsychotics does have some adverse effects, which we do come across in our day-to-day practice, and many a times it does cause a lot of issues either in prescribing or in containing or in managing the clients, because non-compliance many a times does come up due to these side effects. To know a little more about these neurological effects due to the psychotropics, I am sure Susmita will draw a little more light than what I had learned about 45 years back. I hope to learn from her and update myself a little. Susmita, the platform is yours.
Thank you, sir. Thank you, ma'am. It's visible.
Yes.
It's visible.
Good evening, everyone. So today's topic is neurological adverse effect of psychotropics. So here the layout of the presentation. Initially, I'll start with the what are different brain expression, and then mechanism of neurological effects as well as side effects. And then I have divided into neurological side effects into motor, cognitive, sensory, autonomic, and behavioral part. And I'll be discussing the side effects along with the management. Then I have taken some common groups of antipsychotropics: benzodiazepine, antidepressant, stimulant, lithium, and valproate. And lastly, I'll be discussing about the factors that can affect the side effects and pharmacogenetics. So coming to the presentation part, I would like to say that neurological side effects of psychotropics, it's like 150 slide presentation, but we have to make it within 50 slides. So I tried to make a framework, so it will be easy for us. It will be scientific as well as systematical to go through the side effects properly, and then with this framework we can we can further build on it. So as all of we know that brain expressions are sensory, motor, cognitive, autonomic, and emotional. And I would like to put another huge disclaimer is that here in terms of neurological side effect of psychotropic, sorry. So we are only describing brain as an organ itself, but we are not going details into the other organs. What will be the input, or what will be the effect of disturbed CNS inputs on other organs? What will be organ specific adverse drug reaction, and what will be the effect of organ specific intrinsic autonomic nervous system dysfunction. So we are not going to that, and we are limiting our neurological side effects only to the organ, that is brain. So, what is the mechanism of effects and the side effects? See, the mechanism of psychotropics will be the same mechanism will be for the side effects also. Like, we don't have that system that one drug will affect the system or the circuit that we are intending to. So it will affect all other systems. So what we are getting as effect, we will be uh, getting side effects as a collateral damage, I can say. So what are the mechanism? Like we know that there is one thing like affecting the brain circuits through the neurotransmitter, then the messenger system, second messenger, third messenger, fourth, fifth, sixth messenger system, then neuroendocrine system will come into play, and then the coagulation system. So I will be then I want to make one thing very clear, because we are dealing with psychiatric symptoms or psychiatric diagnosis, right? So it's like dysfunction of brain. So in all psychiatric disorder, there will be some abnormalities or some changes in the sensory system, changes in the motor system, autonomic system, behavioral and emotional system. But while discussing the side effects, like whatever studies or observation are there, most of the studies or observation doesn't include the baseline, like what are the baseline function, baseline autonomic, baseline motor sensory function of that person affecting with schizophrenia, affecting with depressive disorder. We don't know that, but we have started as like some psychotropics, and after psychotropics we are assessing this side effects. So uh, the first problem is like we don't have any baseline data, and second thing, with the disease process and with the disease progression or the disease regression or improvement of the disease process, there will be also the change in the sensory and change in the all brain expression. So this is one confounding factor here. So we there is like very like few way to uh, like discard this confounding factor or match this confounding factor, because we don't have baseline data. So whatever side effects we are taking, whatever side effects we are searching through the literature, whatever we are getting, we have to think logically, because it the disease itself can cause this, not only psychotropics that is causing this. So coming to the motor side effect, regarding neurological side effect of psychotropics, usually discussed area is the motor side effects area. So we are all aware of this thing. So I'll be uh, mm, briefly discussing all this thing. So the most common thing that we see in day-to-day practice, that neuroleptic induced Parkinson disease, that is EPS, extrapyramidal symptoms. We know the classic triad is muscular rigidity, akinesia, resting tremor. And the pathophysiology is said that is decreased dopaminergic activity in the nigrostriatal pathway. We know that for first generation antipsychotic, 80% due to a receptor occupancy is therapeutic. For second generation, 60% is therapeutic. And after 60% due to receptor occupancy, EPA starts developing. So we can easily say that for in first generation antipsychotic, EPS will be more, but it's not like that second generation won't show any EPS. We see in our practice that second generation antipsychotic also shows EPS, and even in smaller doses sometimes. So the side effects can be like acute, like early can be described according to timeline, that side effects developing early within weeks, 1 days to weeks, these are considered as acute. Then immediate, actually EPS comes under this immediate category. Then in chronic category we have tardive dyskinesia, tardive akathisia. So what are how will approach this thing? One patient we have started uh, psychotropics or antipsychotic medication, and this patient is showing features of Parkinsonism. So first of all, we have to think that is if there is any temporal association or not. We have started the medication, and after starting or increasing the dose, if there is this symptom started. So if we find this temporal association, one option is we can switch to alternative medication. If that is not possible, then we can decrease the dose. And then if it is not that possible and we are getting some atypical features like bilateral postural tremor or anything that giving us clue that some secondary reason, secondary cause can be there, so then we have to evaluate more for that. And we can give the trial of anticholinergic trihexyphenidyl or amantadine. And if there is no improvement and medication can't be stopped, then trial of levodopa can be done, but neurological evaluation should be done. I have taken all this guideline management approach from the book Medical Management of Psychotropic Side Effects. So coming to the acute dystonia is typical picture is a young thin male. We have started any first generation antipsychotics, mainly injectables like injectable haloperidol, deconate or flufenazine. And after 1 week, within 3 to 4 days of starting this injectable or first generation antipsychotic, this guy is presenting with abnormal position of neck, head and neck, torticollis, spasm of jaw muscle. There can be deviation of eyes like oculogyral crisis, and it can be like involve the respiratory muscle and muscle of swallowing, so can present with impaired swallowing, speaking or breathing. So what is the pathophysiology? As from the clinical symptoms description, what we see that within a few days or like within a week, this patient is getting this symptom. So there should be some, this suggests that acute saturation of D2 receptor plays a definite role, and the studies are going on regarding this pathophysiology of all these side effects. It's not clear there, some studies, preclinical studies suggest that sigma 1 and sigma 2 receptors can be involved. So what do you do in acute dystonia? It's withdrawal. We have to withdraw the offending agent, and we need immediate treatment for that, like IM or IV venstropine or diphenhydramine, that will produce the rapid relief. And in case of when we are seeing a young male thin veiled, and we are giving first generation antipsychotic, we can use prophylactically oral anticholinergic medication, because as Dr. Rajkumar sir also said that adverse effect if patient develops one, we have stigma about the psychotropic medication, and within 1 week patient is developing this kind of side effects where there is stiffness of neck, jaw muscle abnormality, then this patient will be definitely threatened by this, that this medication should not be taken. So compliance issue, with this non-adherence and compliance issue will be there if there is adverse effect. So if we suspect that there is chance of EPS, it's better to start some oral anticholinergic medication for some duration like 4 weeks or 8 weeks, and then we can go further. Coming to the tardive dyskinesia, as I described earlier, this is the delayed form. So it develops gradually, like delayed onset after the starting medication 1 month or 2 months later. Then coming to the medication-induced acute akathisia. So akathisia, it is said that akathisia is the most common is found in psychotropic medication. It's 20 to 40% of patient on antipsychotic develop this. And it's not only the antipsychotics, it was also reported with the SSRIs. So what is akathisia? It is like severe distress, restlessness, and intense dysphoria and inner sense of restlessness. So there is, due to severe distress, there is chance of suicidality also. The pathophysiology is not clear, but is said that the decreased dopamine tone have effect in the VT and substantia nigra, and that alters interaction with the mesolimbic mesocortical system and other neurotransmitter system like GABAergic, cholinergic, adrenergic mechanisms are also mentioned. There can be a form called chronic akathisia that persists 6 months or longer. Tardive akathisia, tardive means delayed. So there is delayed onset of akathisia. So among atypical antipsychotic, risperidone and aripiprazole said to have higher rates. There can be withdrawal akathisia also on stopping of the medication. So how can we pick up? There are some important skill in picking up the side effect. Like in case of extrapyramidal symptoms, there are scales like Simpson-Anger scale. They give there are 12 point in this, and they give detailed description and rating from 0 to 4. So we can rate the EPS. We can rate the severity, and with the medication how much is improving or not, we can find that. And then for akathisia, their scale is Barnes akathisia rating scale. In this there are three components: one is subjective akathisia, one is objective akathisia, and the third one is the global functioning scale. So we can use the scale to level the severity, and we can see how these things are changing with the intervention. So how do you approach with the patient? Like first of all, with akathisia, first of all, you have to see the temporal relationship. If it is there, if there is no relationship with that, we have to evaluate for any other causes of restlessness, like patient is agitated from psychosis, or patient is going any substance withdrawal, or patient is having RLS already. And if we find the temporal association, again we have to try to reduce the dose. And if it is not improved, then we can start with the propranolol and titrate up the dose. And if it is the patient is doing well, we can continue the propranolol. And if we have poor response with that, we can give trial of benzodiazepine, anticholinergic, antihistaminics. But in case of akathisia, the role of anticholinergic is not much. Usually propranolol and benzos takes most part of it, takes cover of it. But if it is not controlled with that also, like third trial line can be amantadine, metazepine. So coming to the tardive dyskinesia. Tardive dyskinesia is like one of the disabling side effects of psychotropics, and it's like other side effects. They are with medication response is good, but tardive dyskinesia, with the treatment, we don't have much treatment. But whatever treatments are there, the response is not as good as other symptoms. So one will say that it is due to the tardive dyskinesia. That symptoms tardive, the term indicating it will be late onset. So the symptoms of dyskinesia should develop after 2 months of the exposure to any dopamine blocking agent, or patient is on medication, or within 4 weeks of withdrawal from medication. And in case of LOI, it is 8 weeks. So, and it should be present for at least 4 weeks. So what is this kind? There will be involuntary movements, dyskinetic movements of tongue, jaw, lips, extremity. There may be lips packing, smuckering, and there may be trunk abnormality. So what is the scale we use commonly for diagnosing tardive dyskinesia is abnormal involuntary movement scale AIMS. This is a very good scale. Like in my clinical practice, I've seen that they have given 12 points, and if we follow the points systematically, it's very easy to pick up the tardive dyskinesia. And who are the higher risk female gender with older age, like 55-year onset of in uh, old lady, like more than 55 years, the onset of tardive dyskinesia is 25% in 1 year. Within 2 years, it will be 34% and 53% after 3 years. So we can see that the prevalence of tardive dyskinesia with the age prognosis. So, and another interesting factor, like we are saying that psychotropics, antipsychotics is causing this tardive dyskinesia, but this kind of movements are also seen that the drug never medicated patient with schizophrenia. So what is the pathophysiology? It said that in other motor side effect, we have read that there is dopamine, decreased dopaminergic activity, but here's the opposite, like sustained D2 blockade resulting the receptor hypersensitivity. This is the most common hypothesis. And another said that oxidative stress and cell death can lead to the increased glutaminergic transmission. That's why sometimes vitamin C and antioxidants are also tried in tardive dyskinesia. And genetic rules are found that polymorphism in the dopamine receptor 2 and 3 and the TAT1, they have higher propensity to develop tardive dyskinesia than the control group. So how can we manage, like we have to like temporal association we have to see, then we have to see for that any pre-existing neurodegenerative disease or any neurologic symptoms are there. If it is there, then we have to treat that. And if it is not there, and then we have to think that is temporal association is there and our antipsychotic is causing that. So if it is mild, then we can monitor for the spontaneous resolution. But if it is severe, then we have to try to stop the antipsychotic. But in real case scenario, that sometimes patient responding with one drug, and it's it's a gamble, like to put in patient another medication if the patient doesn't respond with that. So if it is not possible, then we can uh, like decrease the dose, or if it is possible, we can shift to the drugs like clozapine, who have less propensity to develop EPS or almost zero propensity to develop EPS. So if that is not possible, then we can add benzodiazepine, amantadine, and even poor response, then VMAT2 inhibitor, tetrabenazine, valbenazine, this can be considered. So coming to the drug-induced movement disorder, that what we see like very commonly in our day-to-day practice, like all antipsychotic can induce movement disorder, but along with antipsychotic, like with lithium, on like anticonvulsant or antidepressant can also induce like tremor. Dopamine receptor agonists like levodopa, starting levodopa and patient developing dyskinesia. And as I mentioned earlier, SSRI can also cause akathisia. So this is the list of like we can see that list, extensive list of uh, drugs that causing acute dystonia, Parkinsonism, akathisia, frequent, infrequent, and poorly documented. So I have taken this slide, this table from the book Managing the Side Effects of Psychotropic Medication. So here we can see that extensive list that along with like antipsychotics, acute dystonia can even be caused by SSRIs. Parkinson can be caused by clozapine also. So those are the extensive lists are there. So this is the shortcut list that we see in common day-to-day factors. Tremor, lithium-induced tremor, valproate-induced tremor, we see very frequently with TCA, SSRI, some like with exaggeration of the physiological tremor, some tremors can be there, and antipsychotic is there as a part of EPS or other. and then EPS, antipsychotic sticks stimulant, but it is now controversial. Previously, it used to say that stimulant causes tics, but now it's not like that. Myoclonus can be seen with SSRI, TCA. So what do we do? Patient presenting with tremor with psychotropic medication. So we have to see that it is physiologic tremor or not, or any post tremor is there, or any other condition that can cause the tremor. If it is there, then we have to treat accordingly. And then if there is temporal association and we are like this medication induced tremor, then we have to see that any other Parkinsonian symptom is there along with that or not. And if it is like that, we have to treat as drug-induced Parkinsonism. And if not on antipsychotic, not antipsychotic induced, so we can reduce the dose or lower the dose. And propranolol, we see that with propranolol, like 40, 60 milligram of dose, even 80 milligram of dose, this patient responds, and some patient doesn't respond well, so we can give trial of benzodiazepine. And then if it is there is no improvement, then we don't have any choice. If the tremor is such disabling and problematic for the patient, then we may need to change the medication itself. So the last last motor side effects of psychotropic that I'm going to discuss is the seizure. So it is said that most antipsychotic and antidepressant that they decrease the seizure threshold. So here the list of the drugs like among antipsychotic, clozapine, chlorpromazine have the highest risk and lower risk with the olanzapine, risperidone, and this other newer drugs. In antidepressant, TCA said to have higher risk than the SSRIs. Mood stabilizer, like they already used as anti-epileptics mostly, so we don't get it there. Stimulants, there is like minimal risk of seizure with this medication. Now coming to the cognitive side effects. So motor side effect actually covered the huge chunk of the presentation. Now coming to the cognitive side effects. Again, in cognitive side effects, I want to emphasize on the fact that patient can pre-existingly have some cognitive defects, and with this disease progression, there will be change in that. So in cognitive side effects, this can be acute and chronic. Acute side effects in form of we get only in form of delirium, that is mostly due to the withdrawal of psychotropics or due to the toxicity of the psychotropics. Mostly what we get is the chronic form of cognitive side effects. So coming to the acute form, that is delirium, this is as mentioned, real side effects. The drugs psychotropic drugs or antipsychotics that are having the maximum which are having maximum anticholinergic side effect, that have more chance of delirium. Uh, like acute withdrawal from benzodiazepines can also present with delirium. Polypharmacy or patient having risk factors for delirium, they can land up into the delirium. Chronic cognitive side effects, that is more common. And regarding that cognitive side effects, antipsychotics are hugely discussed, and there is lots of controversy about that. It's said that larger doses of first generation antipsychotic can cause lethargy, somnolence, and EPS, that impairing the neurocognition. But first generation antipsychotic at low dose have some modest neurocognitive benefit in schizophrenia. HGA, it is said that second generation antipsychotic provide greater neurocognitive benefit than FGA, but larger study that CATLAS trial, they have said that the cognitive improvement, like in patient of schizophrenia, we have poor cognitive symptoms. So with this antipsychotics, FGA and HGA doesn't have any difference in cognitive improvement. And it is said that FGA at low dose and HGA at proper dose have almost similar neurocognitive benefit. So this is a list of psychotropic medication, like in mood stabilizer, so-called mood stabilizer. Okay, topiramate among anti-epileptics or mood stabilizers. Topiramate are said to have it has effect on impair the global cognitive function. Carbamazepine, visuospatial processing and learning processes decreased. Valproate, decrease in attention and memory. Lithium is said to have poor verbal memory, lack of spontaneity and creativity is decreased. In antipsychotic, like impairment in attention, memory, visual, spatial function, processing speed, planning. SSRI doesn't have much. TCA, decreased verbal learning, memory. Benzodiazepine, impairing attention. Anticholinergic, cognitive dulling, and gross impairment in attention. So coming to the sensory side effect can also have, along with this, motor and cognitive side effects like paresthesia, numbness, antidepressant withdrawal symptoms like tingling, numbness, shock-like sensations. Coming to the autonomic side effects in schizophrenia patient, it is already found that ANS activity is lower, and antipsychotic medication exacerbate the ANS dysfunction. Like there is reduced activity, and that can lead to cardiovascular mortality and morbidity. So, and it is found that antipsychotic exert a dose-dependent effect on ANS. In close-up in we used to see in close-up in side effect list this kind of ANS related adverse effects like tachycardia, postural hypotension, hypersalivation, hyperhidrosis, dry mouth, blurred vision, constipation. In TCA, SSRI, constipation, dry mouth, hypotension, and the another factor, antidepressant induced excessive sweating, that's come under. So in this section, I am discussing neuroleptic manic syndrome. I'll be discussing very briefly. Like we know, core symptoms are muscle rigidity, elevated temperature, and altered consciousness and ANS system dysregulation. There can be atypical NMS too. Pathophysiology is not that clear, but it has said that this dopamine antagonist that will block the hypothalamic dopamine blockade, and that will affect the temperature regulation and thus causing hyperthermia, and also affect the frontal lobe dysfunction, making altered mental status. And this also have impact on autonomic dysfunction like autonomic sympathetic nervous system and vasomotor and adrenomedullary system. It will have impact. So management is as NMS is fatal, so we have to manage promptly. We have to promptly withdraw the drug, and supportive intervention like IV hydration. These things should be done. So this chart I have taken from CTP. These are the doses mentioned that we can use for NMS, treating NMS. Now coming to the next section, that is behavioral symptoms. At activation, like initial period, there can be disinhibition, impulsivity, insomnia, restlessness, hyperactivity, and irritability. So there is one term is known that antidepressant relevant activation. It says it is seen in early in treatment or following increase in dose, and mostly seen in younger children. So, but in the long run, it is for short term only. But in the long run, this activation doesn't happen, and they have like stable behavioral condition. Now coming to the common side effects of common psychotropics. Here I have excluded the antipsychotic because I have vastly described in previous slides. So I'll be focusing on benzodiazepines, then antidepressant, lithium, valproate, and stimulants. So benzodiazepine, as I have discussed, that they have sedative effect and having effect of anterograde amnesia. And the effect of benzodiazepine depends like risk of amnesia on the lipid solubility. Greater the lipid solubility, greater risk of amnesia. So common side effect: cognitive impairment, drowsiness, motor impairment, inattentiveness, ataxia, anterograde amnesia. It is said that short and long term memory is not sensory and long short term memory is not much affected, but long term memory is affected, and explicit memory is more affected than the implicit memory. Disinhibition mainly occurs due to like long term dose, or patient is taking and there is accumulation of benzodiazepine and its toxic metabolism, and this byproducts are causing the disinhibition. Delirium, like patients having increased risk of delirium along with this benzodiazepine we see in ICU setup. Coming to the antidepressant, serotonin toxicity that can like range from mild to severe adverse effect. It can present with altered mental state, neuromuscular hyperactivity, autonomic hyperactivities. So we have this Hunter serotonin toxicity criteria for the diagnosis. So what is the pharmacological basis? Like serotonin toxicity, excessive serotonergic transmission within the CNS, but there is multiple receptor implicated for that. And if we are using more than two serotonergic drug or co-prescription of like SSRI with TCA and MAO inhibitor, there is more risk of serotonin syndrome. So mild can present simply with mydriasis, shivering, sweating, tachycardia, and we have to observe and we can give benzos if patient is very restless. In moderate altered mental states, autonomic hyperactivity, here we have to be serious. We have to admit the patient with the ICU setup, cardiac monitoring setup, and we have to give the antidote cyproheptadine. And in case of life-threatening delirium, hypertension, hyperthermia, these things are developed. So we have to admit an ICU setup and we have to manage this aggressively. So antidepressant discontinuation syndrome, this occurs with all classes of antidepressant. The antidepressant which are short acting, obviously they will have more chance of discontinuation syndrome than that longer active like fluoxetine, which have 48 hour to 72 hours of half life, and the long run it is 5 days or more. And the highest with the paroxetine. So what can be symptoms? Sensory symptoms can come in form of paresthesia, numbness, and then general somatic symptoms can be there, affective symptoms in terms of irritability, GI symptoms, sleep disturbance can occur. So here another thing regarding like neurological side effect of second generation antidepressant. Okay, so I have in a recent meta-analysis by Joe et al. In 2023, actually they have around more than 30 to 40 studies they have included regarding the neurological side effects, and like surprisingly they have found they have some finding that even I don't I can't correlate logically. They have found that desvenlafaxine and venlafaxine has less tolerated more neurological side effect, but they have like less incidence of tremor and headache. Agomelatine, bupropion, vortioxetine, they have less neurological adverse effect, other have more. But one thing I agree that antidepressant has larger chance of causing neurological side effects in short term. In short time you can see, but in longer time, as the mechanism, I think I like scientifically it will be decreasing the neurological side effects. So coming to the stimulant side effect, it is well said that decreased appetite, insomnia, headache, and there are some studies that say that increased risk of psychosis and tics. But long-term studies, long-term MPH methylphenidate treatment generally safe. Uh, Coming to the lithium side effects, mostly we see the tremor of hand and cognitive side effects. people say that it causes dullness and decrease in creativity, lack of spontaneity, but still controversial. Lithium toxicity, we all know that it can be acute, acute on chronic, and chronic. Acute on chronic, and chronic will be more dangerous because there is more time to distribute lithium in the CNS intracellular space. So we know that lithium has low therapeutic index, and accordingly the side effects and toxicity occurs. And we all will aware with the side effects and the management, so I won't go into details. So coming to the valproate, it says that it causes drowsiness, confusion, ataxia, nystagmus, diplopia, dysarthria, can cause hypotension, tachycardia, respiratory depression, and sometimes in patient with syndromic patient, or they can have more chance of ammonia, hyperammonia, getting into the encephalopathy. And there is one entity called valproate induced cerebral edema that can be due to the altered valproate metabolism, that like toxic metabolism get accumulated and causing this cerebral edema. So what are the factors that affecting? So these are pharmacokinetics and pharmacodynamics property that can affect the neurological side effect, and affecting the drug action, as we have seen, body size. All psychotropic, almost all are lipid soluble. So with more fat, there will be more distribution in the fat cells. And age, we have seen there is some age or more propensity to some side effects. And genetics, yeah, it's very important. Like some patients are developing EPS or other side effect at very low dose that we don't expect, and some patient we keep on very high dose but this having no symptoms. So genetics and epigenetics is there. So the new thing we are with pharmacogenetics and pharmacogenomics. So this is the approach that to get of this trial and error method of trying the psychotropic that we usually do. So what will be the area, like from the drug absorption to the like from pharmacokinetics to pharmacodynamics. So all the steps involved in that, from the from like swallowing, absorption, and then the metabolism, and then going into the receptor level, cellular level. So all this thing, all steps can be like affected by the genetics or epigenetics profiling. This can be done, but till now, the most popular thing is CYP 450 is genetic and phenotypic variation. And then some receptor thing, we are doing dopamine, serotonin, and dopamine amino blocker, and all this related to the neurotransmitter and neurotransmitter receptors and transmission. So we are limited to that. But in real world psychiatry practice, so it's like we don't have much, like we don't have this thing. Patient is coming and we are doing this testing. Yeah, this patient is a slow metabolizer for CYP2D6, so we can give this drug. This drug will work. And so this is like in infancy state. And even the guidelines are also a bit controversial. Like CPIC advice, like pharmacogenetic implementation consortium, says that CYP2D6 poor metabolizers to avoid amitriptyline, but NICE guideline says otherwise. So these are the drugs and the main enzymes. And pharmacogenetics of antipsychotics induced side effect, as I mentioned, mostly are related to the dopamine and serotonin receptor genes, the single nuclear SNPs. So DRD2, and there is tardive dyskinesia. It has been inflated. They have more risk of that. So these are my references. So thank you for your attention.
Thank you, Dr. Susmita. Let's look at the chat box. Yes, Bhaskar Mukherjee always does tell us that there is nothing like serotonin syndrome, but for purpose of the comprehensive presentation, we are not omitting it. That was a remark which he's made. Dr. Prabha asks, why are intellectually disabled people generally more neuroleptic hypersensitive? Sushmita,
Yes, sir.
if you could just throw some light on that.
See, like if there is there is mental intellectual disability or mental retardation, this child is already having poor regarding volumetric structure and the circuitry and other things. These are not properly developed, and some these things are not working properly. So the control system and other balancing systems are, all the systems are not in working in sync in this patient. So I think that is the reason we get more side effects related to them and their brains, like that's what I can say.
Dr. Malay, would you want to highlight anything on this?
Susmita, if you could just
Switch off
stop
your,
sharing the,
stop
yeah.
sharing your screen.
Okay.
Yeah, so what I would think is, I mean, along the lines of what Susmita mentioned, that when we are looking at developmental disorders, the development of the anatomy as well as the physiology is not at par with, let's say, a so-called normal brain. So there are going to be discrepant responses. In the sense, the same kind of a response may not be seen, as well as there could be a propensity or vulnerability to developing side effects. For example, many children who have got intellectual deficit and they present with behavioral problems, and I believe all of us have got this subset of patients where you can literally pump in medication and nothing happens. There is no effect, no side effect, and the doses are pretty much on the higher side or outside the higher side of the range. So this is something that we need to keep in mind, that when we are dealing with not only this age group or with the set of developmental disorders. So again, when we look at neurodevelopmental disorders like autism and an autistic child who has got, let's say, hyperactivity or inattention, the response to the standard stimulants is not the same as going to be, I mean, if you compare it to somebody who has only inattention and no ASD. The same thing happens at the extremes of age. So when we are dealing with dementia, the dementia group of disorders, where what has happened over time is that because of the neurodegeneration, again, what was the substrate that was necessary for drug action is not so-called normal. So again, we have got a lot of problems there. Even small doses can cause a lot of severe side effects or poor tolerance and things like that. So yes, that is what I think is probably happening.
Okay, I would also like to add something. The thing is, we have to understand when. Okay, I have to start the video. Yes. The thing is, when we see intellectual disability patient, that's why I actually was not on turning my video on, because I am in a car. The thing is, we have to understand that not all group of intellectual disability patients are more prone to develop hypersensitivity towards neuroleptic. This group, which has hypersensitivity to neuroleptic, they are a specific group. They are syndromic intellectual retardation patients who have genetic defects in their brain, which involve either the way their brain handles the various motor related tasks, or the way their brain handles the various excitatory neurotransmitter metabolism or excitatory system metabolism. In this patient, whenever we give neuroleptics are drugs which reduces cerebral excitation. So this group is already vulnerable towards developing it, because their excitatory system is not working properly, their motor system is not working properly. So by giving neuroleptics, we are reducing the excitation more, the basal ganglia function gets dampened more, and they develop this kind of which are motor side effects. So how we can predict that? If MRI shows there is basal ganglia abnormality. If the child's behavior shows that there is motor abnormality or there is neuromuscular dysfunction, or we have found out that there is high level of mitochondrial dysfunction in the child, then this child would be inevitably prone to develop motor side effects of neuroleptic drugs.
Divya Mangla wishes to know how common is valproate-induced cerebral edema, any risk factor, and how does it present? Similarly, any specific risk factor for hyperammonia?
So, like valproate-induced cerebral edema is not that common entity. It's basically rare. But the patients who are having syndromic diagnosis, like I can give one example, like patient with Sturge-Weber syndrome, they will have seizure, and we have given valproate, so we have to be cautious with that child because they have already like disturbed hepatic metabolism, and there is more chance of hyperammonia. And any patient whose liver condition is impaired or affected, or anything that can impair like ammonia metabolism or this thing. And mostly in case of syndromic child, we have to be cautious while giving valproate medication. Even in case of like IDD having some syndromic diagnosis, and we are giving medication like valproate for management of behavioral issues or something, but we should go like titrate slowly and see it is like mostly in case of syndromic child we can see this or expect this kind of side effects.
Any comments from Dr. Dave?
Do you think that we should regularly monitor ammonia levels in all our patients, irrespective of whether they are syndromic or irrespective of the diagnosis? Whenever sodium valproate is given, do we make it a point? See, the rare things are rare, means we don't really
Yes.
get into it on a day-to-day basis. If it happens, then it is sheer one of those rare things that can happen. But sodium valproate is a very widely used drug. So do
Yeah.
we do that?
Sir, we don't usually do that thing, but if a patient having like issue after starting, like if we find some temporal correlation, like after starting valproate or increasing the dose of valproate, we are getting some signs of valproate toxicity, like altered sensorium or other things other than tremor or like simple tremor. We deal with all this, but when we get some alarming signs like that is affecting like mm, uh, like altered sensorium or other things, then we go for serum valproate level. But
Ammonia, serum ammonia, you mean?
sorry, serum ammonia. Sorry, serum
Okay.
ammonia.
Yeah. So
Divya
on a regular basis, not needed.
No, sir, not needed.
And if the responses are okay, within our how would you say, clinical range from not much response to some sedation, till that time we need not worry. Only when something, suppose, at 250 milligrams of divalproate, there's a lot of sedation, then I think I would go in for a serum ammonia. Or if there is a history of alcohol going on and something like that. So definitely then at that time, when there's a concomitant medical illness, then it is better we do it as a baseline, but otherwise not needed.
Mangla also wishes to understand, is spontaneous TD management different? Means TD which is not drug induced.
Drug induced, one thing I have said that in TD, tardive dyskinesia can also be present in drug naive or like never medicated patient of schizophrenia and other patient also. So in case of drug, if there is like temporal association, then we have to do with the drug, like decreasing the dose or switching. That is one part. But other part with the TD, like where there is spontaneous, we have to like for the movement, we have to see that if it is disturbance causing like patient is it is causing disturbance or patient is not okay with these things. If it is like minor side effects and patient minor movements and patient is okay with that, we can wait for the spontaneous resolution of that. With the disease itself, like if the symptom improve, there can be chance of improvement. But if it is major that is causing problem to the patient, problematic for the patient, then we have to go for the treatment. One option is there, like in some patient with VMAT2 inhibitor, like tetrabenazine, valbenazine shows like good response in some patient, like tetrabenazine 25 to 50 milligrams, starting with 25, then gradually hiking up to 50. This response can be seen, and that is how it is different. In drug induced, we have to try decrease the dose or try clozapine or other drugs that have decreased propensity. And then if it is not controlled by them, then the same treatment, like treatment with benzodiazepines or other things, or going to the VMAT2 inhibitor.
So, if there is dyskinesia without any relation to a drug, why call it tardive? Because tardive means there is a certain point in time where something is happening, and as a result of that, I mean, you're measuring the time interval from that
Yes.
incident, which is in this case a drug or a medication that you're giving, and you're waiting. I mean, over a period of time, something happens. But when
Yeah.
it is a dyskinesia going on, how will you decide what is the time frame? It is a dyskinesia.
Yes, sir.
And probably that dyskinesia, we have idiopathic Parkinsonian syndromes and we have got drug-induced Parkinsonian syndromes.
Yes, sir.
Even though the pathophysiology is similar, it is not the same.
Yes, sir.
So there is no point in calling, I mean, at least clinically, that something is tardive if you are not able to establish a relationship between the parameters. With drug-induced tardive dyskinesia, it's very clear that patient is on something, and then after a
Then
couple of months or 3 months, something is happening. So that would be tardive,
Mm.
because you can kind of see the process right from the beginning. But if there is a dyskinesia syndrome, there can be independent dyskinesia syndromes.
yes.
But I don't know whether we would call them tardive, because if you use the word tardive, then
Yes,
we kind
and
of
then yeah.
mistaking, or we would completely go off tangent. We'll keep on trying to figure out, is there some drug involved or something.
Yes, sir.
We can have
Like
dyskinesias as independent movement disorders without any relation to medication.
yes, sir.
And
And for
as
the
you mentioned,
medication,
this kind of things we might miss, because they can also be there in a psychotic disorder.
yes,
Psychotic disorders are not only delusions and hallucinations, they can have a lot of movement or a motor component also.
sure.
So it could be there. So yeah, the thing is that if we are able to identify, we might mistake it for just kind of stereotypes or mannerisms in a psychotic patient, but it could be a dyskinesia.
Yes.
And that is definitely going to worsen if we are going to use our molecules.
Yeah,
Okay. Yeah. So on similar question has been asked by Dr. Jagjot Singh. Why would a patient have TD in a drug-naive patient? So I think there are independent syndromes, and
yes,
dyskinesia is also not only related to medication. But the
yes.
second question is important, and you can answer that. Can tetrabenazine worsen psychosis?
Tetrabenazine, like there is a possibility, like I have seen in the literature that yeah, it can worsen, but not that frequent. But it can.
So in your clinical practice, have you given a patient is on antipsychotics, patient is doing fine apart from the TD, and now you are in a fix that psychosis part is controlled, but then all these grimacing movements and smirking movements and whatever dyskinetic movements, you would add tetrabenazine to what is going on, or what would you do, or stop antipsychotics?
So this is tricky. Like if it will depend according to patient profile. Like it's like a gamble. Like some patient that like I have seen that with I have tried two drugs, and after that with some drugs this patient is having response, like psychotic symptoms is improved. For that, here my hands are tight. Like I can go further trial and error with the patient. Like with this drug, patient is developing tardive dyskinesia, but in this case, I'll be like, I won't stop this medication. I can try decreasing the dose, and with the dose decreasement, if the psychotic symptoms worsen, then I'll keep the dose like that, and then I will add other agents like benzodiazepine, tetrabenazine for this kind of patient. Like,
So my point is that you can add, let's say, tetrabenazine to antipsychotics,
mm,
ongoing regimen.
yeah.
And whatever you do with the dose, increase, decrease, whatever you want to do. But yeah, because one of the things that is always mentioned with use of tetrabenazine is that you shouldn't mix both the things, because one acts, I mean, both this act supposed to act contradictory
Yes.
to each other. Okay.
And one thing like clozapine can be added. Like clozapine, it has been seen in some studies, though I have not used much. One patient I did like I totally but with clozapine there is
just a minute.
Just Susmita, just a minute. Please mute yourselves. There's a lot of disturbance going on.
Mute yourselves if you're not speaking. Only the speakers switch it on.
Yes.
Yeah, go ahead, Susmita.
Yeah, so with like one patient, I have totally switched to clozapine, and with clozapine, this within 3 to 4 months of treatment, this total tardive dyskinesia is gone without any other treatment like benzodiazepine or tetrabenazine. So, but in another patient where with risperidone, she had response, but uh, I didn't switch to other drugs with tetrabenazine 50 milligram dose. She was fine. Like it took time around 6 months to like totally, but some kind of movements were there. Total resolution was not, symptom resolution was not there. So this.
Okay.
Paresha wishes to know if bleeding tendencies are seen in SSRIs, like
Bleeding.
epistaxis.
Yeah, it said that because SSRI, like this serotonin, these are present like in platelet. Uh, they can affect the platelet aggregation and then affect like bleeding. There is more chance of bleeding. So regarding this, like serotonin contains this like in the platelet cells. So there is a literature going on, like literature is there regarding that which SSRI has like maximum chance, lowest chance. Like in case of SSRI, it is said that all of the SSRI has almost like bleeding tendency more. Like in it is in TCA the bleeding tendency is less than that of SSRI. But I like still doubt like in patient where there is, it is said in guidelines that in patient with CVA, like where there is hemorrhagic stroke and patient is having like post CVA patient is having depressive symptoms or other symptoms, we try to use antidepressant. Is better to go with like nortriptyline TCA type rather than SSRI. And in SSRI, it is said that meters and other this SNRI, this group has decreased chance of bleeding than that of SSRI group.
In my practice, I have seen that there was one family, maybe this could be in the family, some genetics could have been there. Both were on escitalopram and both had patches, black patches all around the body, stopped the medication, switched on to another SSRI, it stopped. So this is one incident which I can just quote from my practice. Could have been familiar because there could be both mother and the daughter had this. So maybe some genetic issues could have been there, perhaps. Oh, I think that is, yeah. Will amantadine be helpful in TD?
Yes, it can be helpful in some cases.
Should anticholinergics be prescribed into TD?
In clinical practice, it has been said that anticholinergic doesn't have much effect on in TD, like they don't respond in TD. And in guidelines also, they don't focus on anticholinergic to give in patient with TD.
Nachiketa Desai wishes to understand acute dystonia presenting as spasm is easy to differentiate from dyskinesias. But how can we differentiate dyskinesia from dystonia in the case of involuntary movements?
In case of if we go by the clinical feature of dystonia usually affects the jaw, neck muscle, jaw muscle. Then there can be these movements are more like mm, the what I should say, the intensity of the movement and the frequency of the movement. These are different from dyskinesia and dystonia. Like in dystonia there will be and we can if we see the group of muscle involvement, in this dystonia there will be one group of muscle involvement, like this antagonistic muscle effect is gone. I am having a patient is having the stiffness of neck or torticule is going on. So there is the movement of opposite muscle things are gone, and the synergistic action, muscle action is going on. So in dystonia, this kind of group of muscle involvement is there. But in case of dyskinesia, there is nothing like there is this kind of movements is not there. These are involuntary subtle movements. These are seen usually in the eyes or perioral areas or in the jaw region. That is one difference.
So is it true that when we are talking about dystonias and dyskinesias, one of the differences that in dystonias there is an abnormally increased tone, whereas along with the involuntary movement, that is whatever it is, twisting or whatever, whereas in dyskinesia the tone remains normal. So when we
Yes.
clinically assess and when you're looking at, so whenever there is this oculogyric crisis and you feel that tone, this is
Yes,
going to be hypertonic. But when you look at all those coriform and ethetoid movements, there is usually not a tonal disturbance. That's why it's called as dystonia, means a disturbance in tone, and there is a dyskinesia, which is a disturbance in the movement.
Rhythmicity, and
So when we do a, you had mentioned some tests, I mean, the commonly used clinical scales, but
yes, sir.
apart from that, when we do a basic clinical examination, okay, it is worth doing these basic things: tone, posture,
Yes, sir.
that way. So whenever
Rhythm.
the tone remains okay or it is slightly less, then it is most likely going to be a dyskinesia.
Yeah.
If I may, please feel free to, any of us can answer that question. Either Susmita, Malay, or Bhaskar can jump in as well. Any comments on the seizure threshold? And if somebody already has a pre-existing seizure disorder, what would be your first choice of a psychotropic?
Let Susmita answer. She has given a nice list, so we can learn from there.
Sir, regarding it said that all psychotropics lower the seizure threshold. So in that, if patient is already seizure disorder or some condition that is lowering the seizure threshold, so here we can go by literature wise, or what we say that with clozapine there is highest risk of decreased seizure threshold. So we can shift to the other drugs who have lower seizure propensity, like risperidone, olanzapine. In case of antidepressant, if we're going to the antidepressant group, then the drugs like fluoxetine, they have more propensity than the other. TCA have, if we have to choose between TCA and SSRI, TCA have more propensity than SSRI. And among SSRI, it is said that fluoxetine, paroxetine, this kind of drug have among SSRI and the other escitalopram, they have lower propensity to cause this. And other group like lithium, valproate, this valproate already anti-epileptic, so we don't have to go that this and other groups ticks. It is said that methylphenidate can decrease the seizure threshold and provoke. So in these cases, we can prefer non-stimulant like atomoxetine or other drugs, clonidine.
No, in fact, recent current studies say that stimulants do not really cause that much of an interference with the seizure threshold, so it's okay.
Yeah, sir, I was finding
So
that controversial finding in tics and seizure. Like previous literature are saying,
even with tics, it is
Mm,
now we need to reconsider that. So
yes, sir.
so in some it can happen, but it's not a
Yes, sir.
universal phenomenon. So because in patients, again, when you look at neurodevelopmental disorder, whether it is tics, whether it is autism spectrum disorder, it's inattention. Sometimes
Yeah.
these go hand in hand. So you have no option but to treat.
Yes, sir.
So
Already
probably
having
you will have
comorbid tics or
so you'll have to kind of take a chance, do a little bit of a trial and start low dose and things like that. But yeah.
Sir, I want to ask one question. Like previously, there was like guideline was there patient with ADHD, child diagnosis with the ADHD along with tics. So the child who have prefer non-stimulant and child that are having no tics stimulant. So is that holds right now also? Like I searched it a lot, but I could not find a solid like.
No, it will. I think it's best. I mean, whatever you're comfortable with, you start and see what happens to the other component.
Okay, sir.
Because there are still people who would not give us stimulant to proper clinical all criteria fulfilled kind of ADHD if there are tics.
Dr. Alia Khanam wishes to put forth a view also that reduction of antipsychotics might worsen the TDs at times.
Yes.
There was a hypothesis earlier on saying reduction of an antipsychotic can worsen the TD. Does it stand true or is it?
Like what I can think as of now with the question, like if the TD is like due to the disease process as in schizophrenia patient, they can not TD, they can have dyskinesia. So if the schizophrenia symptoms are worsening and with this disease process, this can worsen, but other thing I'm not sure. I'm just thinking of it, and that what I can think of it, but I didn't find anything like recent literature saying that lowering the dose of antipsychotic can worsen dyskinesia, no? Like TD or dyskinesia.
Yeah,
I didn't.
there was an older theory which or a hypothesis which suggested that the dopaminergic system, post-synaptic dopaminergic system becomes very sensitive because it's been blocked over time. So
Hypersensitivity.
by that, even little dopamine, whatever is there in the synapse, produces this kind of thing. So that was one of the understandings. So, but yes, we are in psychiatry, we're in the domain of hypothesis. So it could be one of the things, but it is not the only thing. The more you understand those movement pathways, there are a lot of other things that get involved. And that's why the management of TD is widespread. It is not only focusing on just one neurotransmitter, that is what do you do with dopamine.
So I may add to it.
Sorry?
Right. So I may add to it. Even using tetrabenazine, it depletes dopamine. Given the hypothesis, does it increases dopamine or
it's
does
a
it decrease dopamine?
it's a VMAT.
VMAT.
So it reduces the amount of it kind of reduces the number of vesicles opening up into the synapse. So the amount of dopamine in the synapse is reduced.
Which means it's sort of a dopamine antagonist.
It Yes.
And it is also used for antipsychotic induced movement disorder.
Yes, it is. It is
Yes.
primarily used for that, I mean, for us. But neurologists
So,
also use it for all kinds of dyskinesias.
my question would be that, it is actually complex indeed.
Hmm.
Just use of the word dopamine, if we use and increase and decrease, would not
Yeah, that
satisfactorily
is
give
true.
an
Yes,
explanation
yes.
to what exactly is.
So that is what the whole thing is, that all patients of TD or dyskinesia do not respond to
Do not respond to.
tetrabenazine or valbenazine or whatever.
So
So
can I rephrase the
uh,
question rather than should increase or decreasing the level of or using antipsychotic for long term causes TD or dyskinesias, or a rapid increase or decrease, sudden increase in the dosage or sudden decrease in the dosage of an antipsychotic can also induce TD? And if yes, should we not do that?
sudden increase or decrease, if it is there, it might not, the disorder as we diagnose evolves over time. And it is not only medication related. There has to be some kind of vulnerability. See, for all side effects, whatever we have discussed today, unless a person is vulnerable, side effects don't happen. So you can give, as I'm just treating somebody who is IDD, who is a adolescent, who has got syndrome, autism spectrum disorder, who is non-verbal. The only thing he can do is shout and scream. And for this boy, all the low doses have not worked. He's on very high doses of, he must be at least 20, 20. I have tried all possible things, including clonidine, including everything. And at one point, he was on some 20, 25 milligrams of haloperidol and with no effect, no side effects. So whatever we are talking about today is nothing absolute in the sense,
Nothing absolute.
yeah, it is, yes, medications can produce certain things, but they do not produce things de novo. There has to be a substrate which is already there in place. So if I'm vulnerable to TD, then I might develop TD. In fact, most of the patients who are on long-term typical antipsychotics, the previous generation, first generation, or the older generation, they do not have TD.
Right.
In fact, TD it's not a very common thing. There
It's
are
not
people
that,
who
but
are
it
on.
is overly discussed. In fact, then I think the next question I was expecting it came was tardive dystonia. We'll be discussing anything and everything about tardive disorders. Then, adding to that, I would like to share another case or just one case from my side because I want this message to be conveyed, what Dr. Malay just said, and how important it is. So patient, so-called schizophrenia, young patient, young female, in her teens. Uh, every antipsychotic has been tried. Clozapine, thinking that it is resistant. Patient was abroad, and even they tried all the antipsychotics. I have a list of it, and then they tried ECT, and then I think more than 20 sessions of ECT were given, and they said she's not even responding to ECT, and that's when the mother came to India. And then, a psychiatrist, not me, somebody started haloperidol. And then it turned off, or they stopped it. She came to the clinic and she was pacing. She was not able to sit. So she was walking around, looking at everything in the clinic. And it didn't stop her. I wanted to see what is exactly happening on her. I saw the treatment mother was a registered nurse, still is. And I asked her, is she on antipsychotic? And she knew all antipsychotics by heart. That was probably the reason why she was not improving at the same time, because she was not aligned with the treating consultant to use the antipsychotic to the full advantage. And she was blaming olanzapine for something, risperidone for something, saying these caused agitation in her. She was pacing left, right, and center, thinking that it is akathisia and the drugs have caused it, and now don't put her on antipsychotic. She was put on haloperidol. I started with very low dose, 1.5 milligram twice a day, increased 2.5 milligram twice a day, 5 milligram twice a day. Along with lithium, she had a lot of mood symptoms. She would just burst into laughter without any reason and then tell me that I am not doing this. I don't want to do this. And all she could say was like, sorry, and then she would laugh again. it was so hard to convince the mother that please don't think that it is drug-induced side effects. She's not on antipsychotic. It is happening. Now treat it as a part of the disease. Definitely, I had to add beta blockers, and she started responding. The pacing started to go down with increase in the dose of antipsychotic under the cover of propranolol. Her pacing decreased as I started to increase haloperidol. I thought she's vulnerable and I thought she would, this could worsen and she's not going to improve and, this and that. And my own personal bias was there, which I had to put aside. And I think indirectly I had discussed these findings with Dr. Malay and over the group also, which led to me knowing and accepting that just because a drug can have a side effect, we should not assume that the patient is going to have that side effect and not use one molecule. Just because she has been put on every antipsychotic and the mother says there's nothing worked for her and ECT didn't work for her doesn't mean she had a fair trial of pharmacological intervention. Now she is on haloperidol, she's went back. And the psychiatrist over there again said that no, she was pacing in my clinic. She has having these symptoms because of Haldol. And I have vividly written a note on the prescription to be seen by any psychiatrist who would, because this was an eventuality, that this is not a drug-induced side effect. It is a motor symptom of psychosis. Please look at it that way and not stop haloperidol.
No, I mean that's a good case, yeah. But
So-
but on that note, I'll just interrupt you there. So suppose I have given a child who has ADHD with severe behavior problems, 0.5 milligrams of risperidone. Child is better. The child is now then continued on stimulants for ADHD, and we have stopped risperidone. Suppose this child at 60 years of age develops Parkinson's, the neurologist is going to say drug-induced Parkinson's.
Drug-induced Parkinson's.
So so we have
Even
got
the worst case scenario is ADHD kid put on methylphenidate, started responding, everybody happy, mother super happy, comes in the OPD, gives mithai ka dabba, then the child develops tics. The whole family comes. Our neurologist is our solely doctor, family physician, or maybe the neighbor who is not even 10th pass told us that your medication can cause tics, and because of this, his life is worsened now. Now we can't go to dinners because he is having these motor tics and we feel so ashamed. So that becomes very important in the first visit or in the subsequent visit to take a detailed history of tic or tic disorder prior. Tell the parents these are there and these are tics which are already there. So if you feel that the drug is causing, I'm telling you they are there. There is a possibility of worsening. Do you want to take that chance? Take them into confidence, because yes, we know they have a vulnerability and that can worsen, right? The parents are not going to say that. For them, the social aspect, I hope Dr. Bhaskar is listening to this line. For them, it is the most important thing. And we, thinking from a biological perspective, have to tell them the biological perspective. And in that note, it makes us, gives us a safer space to treat that patient and have a free hand.
So
That's all from
informed
my side.
decision in this kind of case, and in patient with like pregnancy or other things, like how the skeptical there, but yeah, we can like point out this thing causing this. So here, like I also started writing this thing, like risk benefit or explain.
Yeah, but writing such things sometimes make the patient more skeptical. It's a double-edged sword. I learned it in a real, I learned it later. I did the same mistake. And then when I found out that, yeah, so to each his own.
Yeah.
Thank you, Dr. J.J. Singh.
Thank you,
Yes.
sir. Thank you so much.
Dr. Divya Mangal wishes to understand any literature you have on TCA-induced blepharospasm, as he has seen a few cases and has been having some time or difficulty in handling them.
I have not seen personally TCA induced.
Any literature available, Malay bhai?
Then in case of this, like Botox like this is in severe cases, like as in case of tardive dystonia also, like they don't usually respond, and if it is very problematic for the patient socially or other things. So Botox can be tried in this patient, Botox injection.
Again, the same thing would be what you have said before, what Dr. J.J. Singh said about his case. Establish a baseline as much as possible.
Yes.
Anxiety related, mood symptoms related, psychosis related,
Substance related.
movements from the word go are there.
Yes.
We need to kind of see what is there, not there. So we are in the clear that, okay, this is medication related, this has come new, but since there was something already there, this is an extension of that. This is what we are seeing right now.
Yes.
So the treatment of blepharospasm would be, I mean, nobody's stopping you from treating that. So it could be an independent thing. It could be, it could also happen that this patient would not have had depression and develop some kind of facial dystonias or dyskinesias as a syndrome over time. We don't know. Things can happen independently also.
Yes, definitely.
So last comment or question?
Yes. You can choose.
Yeah, you can
Entirely Dr. Rajkumar.
choose.
I'm just reminding it's 9:30.
I think Satyan does ask that again, a confusion of untreated symptom of the disease.
So that is what we look at. I'm sad and I'm feeling suicidal, and that's it. There are motor symptoms, there are cognitive symptoms, there are other symptoms in all disorders, and the idea of the topic was that there are neurological adverse effects of psychotropics, and we are not limited to only one drug or one category of drugs, all of them. And that would mean that if all of them can produce, precipitate, whatever we say, it means that there has to be a vulnerability, and that is mandatory. That makes it mandatory for us to ask some questions, try and figure out from day one, like what is happening, so we can treat our patients better. There are, of course, medications, whatever we have at our disposal, we can try and use it in a very rational way.
Yeah. Thank you, Dr. Malay, Dr. Susmita, Dr. Jagjot, Dr. Rikshada, and all you friends who have chipped in. We will be meeting again after a fortnight with another subject, another speaker. Till then, I would say goodbye and good night, thanking Alchem Neurosciences for the logistic help. Good night to all of you.
Good night. Bye.
Bye. Thank you.